Hello, gorgeous, and welcome to the Midlife Realignment. I'm your host, Esther Blum, and I'm here to disrupt the narrative on perimenopause and menopause with humor, nutrition, hormones, and fierce self-advocacy. Together, we'll rewrite your story and the rules because there's a light at the end of the vaginal tunnel. Let's go. Today's solo episode, 5 Things Your Gynecologist Probably Got Wrong About HRT, was inspired by my most recent visit, my annual checkup with my conventional GYN. She is not my functional GYN. She does not handle my hormone prescriptions. And I went in for my visit, and she was reviewing my current HRT prescription. She said, "You're on a really high dose of progesterone, and that can cause cancer, and you don't need it now that you don't have a uterus." And I just took a breath and I said, well, not sleeping every night will surely increase my risk of cancer. And she just looked at me and nodded. And I was like, believe me when I tell you, I have tried everything from cognitive behavioral therapy to supplements, to treating chronic gut inflammation. And if I don't have progesterone and a supplement stack, I don't sleep. So she then told me that I no longer had a cervix. And I said, yes, I actually have a cervix. And she said, well, your pathology report says it was removed. And I said, nope, my surgeon and I discussed it, and I certainly do have a cervix. So at this point, I just laugh because the misinformation out there is so rampant. And I personally don't have the energy to have these conversations and the back and forth because I have a functional GYN who prescribes all my hormones. So, but I thought, if I'm in this and this is my zone of expertise, I know a lot of you out there are struggling with this. And I know this because you're DMing me. So here we go. This is for you. So, if you have walked out of your gynecologist's office like me, feeling gaslit and dismissed, or you were prescribed birth control instead of HRT, or you're told to come back when things get worse, this is why I'm recording this today. I'm going to walk you through 5 things your gynecologist probably got wrong about HRT and what the science actually says. And some of these are going to piss you off, and that's a good thing. Stay pissed off. That's exactly the energy you're going to need to advocate for the care you deserve or walk out and find a new provider. And if you stay with me to point 4, I'm going to tell you exactly how to get HRT in the middle of the worst estrogen patch shortage we have seen in years. Now, bear in mind, most doctors and prescribers are not malicious. They're kind people, but they're undertrained. And menopause was barely covered, if at all, in their education. I talk about all of this in my upcoming TED Talk. And the field stalled for 20 years after the Women's Health Initiative panic in 2002. So 24 years ago, women are still paying the price, even now that the FDA has removed the black box warning. And this, by the way, is what has caused the surge in demand for estrogen prescription and why women are struggling to get patches. So there is an upside to the shift happening, which is women are aware and wanting treatment now, but we have supply chain issues. And I want to be clear, I'm not anti-doctor or anti-provider, but I am pro-women getting the care that they actually need. So here's my first point. I want to talk about the importance of early intervention and why it matters. We've all heard the misconceptions from our providers, like, wait until your symptoms are bad enough. You don't need HRT now. You're too young. Let's just wait and see and retest you in 6 months. And the reality is perimenopause can start in your late 30s and last up to 10 years. And by the time most women are diagnosed, they've already lost years of bone density. They've lost cardiovascular protection, brain health, and muscle mass that they will not get back without a fight. And so this is the limiting hypothesis that is now well established, is that starting HRT early in the menopause transition activates estrogen receptors in the tissues that respond well. So tissues in our blood vessels, our bone, our brain, our pelvic floor. The problem with waiting too long is that those same tissues become less responsive, which is why timing of initiation matters as much as the therapy itself. Early intervention is just the absolute gold standard to me in perimenopause care. And what it does is it protects your bone density before your fracture risk skyrockets, supports your cardiovascular elasticity before plaque starts accumulating differently. It supports insulin management also, so you're not laying down plaque. It supports cognition during the perimenopausal window when women are statistically the most vulnerable to depression, brain fog, not feeling like themselves, anxiety. And it also preserves muscle mass while you can still build it easily. Now, you can build muscle mass at any age, but it's a longer, slower game once your hormones have dropped. And early intervention also prevents that slow grind of sleep deprivation that just destroys your metabolic health and your cognition, your blood sugar balance, all those benefits. So if we follow that wait and see approach, it's going to cost you years of lost productivity. It puts a strain on your marriage. The statistics on financial losses and career struggles are dramatic because of menopause, and women in perimenopause and menopause are leaving the workplace in droves because they can't do their jobs anymore, which has economic realities. And there's also mental health struggles treated with antidepressants when the underlying cause has been hormonal this whole time. So 20%, I would say about 20% of my practice has women who were prescribed antidepressants or anti-anxiety medications. And across the board, they all told me, I thought I was going crazy. And the medications got them off the ledge, but they did not address the metabolic dysfunction, the root of the insomnia, which is hormone deficiency and shifts in your gut health and neurotransmitter production. Does not address the weight gain or the genitourinary symptoms like getting up to pee 3 times a night or vaginal dryness or UTIs. So here's what I want you to take to the bank. Early intervention is not aggressive. Waiting is aggressive. Waiting is what costs women their bones, their brains, their muscle, and their lives. Point 2. Here is why birth control will never be the same as HRT and is so often doing you dirty. This is the section, to me, of our talk today that needs the most clinical precision because women are so routinely put on birth control in perimenopause. And by the way, they're put on birth control in their teens for irregular cycles. They're put on birth control in their 20s for PCOS and cramps or moodiness or acne. And then in perimenopause, they're put on it as a fix and told it's the same thing. It's a huge misconception, by the way, that birth control will regulate your hormones and suppress crime scene periods, or it's basically HRT, or it'll handle your perimenopause symptoms. The truth is that birth control was never FDA approved for the treatment of perimenopause or menopause. That is an off-label use of the pill. And the reality is birth control and HRT do almost opposite things at the cellular level. So birth control suppresses your ovaries. It suppresses your production of progesterone, so you cannot ovulate. If you cannot ovulate, you cannot get pregnant. So if you're using birth control for birth control, it's going to work. If you take the pill, if you have an IUD, you're going to suppress your ovaries. It shuts down your natural hormone production, though, and replaces it with synthetic ethinyl estradiol, which is roughly 4 to 10 times more potent than the bioidentical estradiol in HRT. So it turns your hormones into a desert wasteland. It suppresses them so dramatically. HRT supplements the hormones your body is losing using bioidentical molecules that your cells recognize. So you are replenishing. Also, when your ovaries are suppressed and your progesterone production is suppressed on birth control, you will experience worsening anxiety and depression and rage alongside insomnia. So, what birth control gets wrong in perimenopause is that it masks your symptoms instead of treating the underlying decline. So, can it stop crime scene periods? Yes, but so can high dose progesterone. Birth control pills also carry a higher clotting risk than transdermal estrogen, which carries zero risk for clots, even if you have factor V Leiden, even if you've had deep vein thromboses, you can still use transdermal estrogen. The pill also depletes nutrients. Nobody realizes this. No doctor who prescribes it will ever tell you the pill depletes nutrients, including B vitamins and magnesium, and it can blunt libido. And it's crazy how it changes your sense of smell. So you can be attracted to a very different partner on the pill than off the pill. I mean, how wild is that? And again, it doesn't address the root issue, which is that your ovaries are starting to retire and wind down the party. And worst of all, birth control does not provide the cardiovascular, bone, and brain protection that bioidentical HRT does. It's a different drug doing a different job. The bigger pattern also is that women in their 40s are walking into the gynecologist with brain fog and mood swings, weight gain, irregular bleeding, and walking out with a prescription for the pill or the IUD. Their doctor genuinely believes they're helping you. They are not. They're kicking the can down the road and creating new problems on top of the existing ones. And you may be thinking, Esther, I'm not giving up my birth control because I've been on it so long. I don't want to upset the apple cart. I do see women on birth control who start adding in progesterone in perimenopause, who start adding in bioidentical hormones, and then they can wean off the pill. If you've been on the pill a long time and you want to move over to HRT and stop the pill or take out your IUD, you will probably need to start at a higher dose of HRT than someone who hasn't been on any hormones. So give yourself time to transition. You may hot flash a little when transitioning off. It will take about 2 to 3 weeks for your body to adjust, and then you will adjust. But here's what I want you to take to the bank. Birth control is designed to prevent pregnancy. HRT is designed to replace what your body is no longer making. They are not the same drug. They are not even on the same team. And if your doctor or provider told you they were, they got it wrong. And if your doctor only wants to provide you a prescription for birth control, but not give you the option to do HRT, find a new provider, clearly. The next thing I want to discuss, and this is something I talked about in my TED Talk, it's really something I'm so excited to talk about and change the landscape on, is this. It is never too late to start HRT. The misconception that women have been sold is that you're past the window. It's been more than 10 years since menopause. You've missed it. You won't get any benefits from starting it now. Starting now is too risky. But yet, so many of you are still having symptoms. You're still having vaginal dryness. You're still having insomnia. You're still hot flashing. Women in their 70s and 80s and 90s can still hot flash until the day they die if it's not treated. It doesn't go away on its own every single time. Many times the symptoms don't improve and get worse. And I know this because I have so many DMs on Instagram from women who were yanked off HRT when that Women's Health Initiative study came out, who now want to start again, but can't find a prescribing provider. Or I've had women in my practice who said, I've been on HRT for 10 to 15 years. I want to come off it now. And I'm like, I don't think that's a great idea, but it's your body, your choice. They come off it, they regain the weight that they've worked so hard to lose, and they start hot flashing all over again. So they go right back on. So your symptoms do need to be treated. And the reality is that 10-year window or before age 60 guideline is the FDA's labeled recommendation. Again, that is sorely outdated. If you were a diabetic and you needed insulin, you would stay on it the rest of your life. If you had hypothyroidism and needed levothyroxine or Synthroid, you would stay on that the rest of your life. And when my clients ask me, well, when do I stop taking hormones? I say, till death do you part, every single time. Stay on them. Hey, gorgeous. To preserve muscle in midlife, you need at least 100 to 120 grams of protein every single day. Most women I see in my practice are getting half of that, and they have no idea. They're skipping breakfast, picking at salads, or calling a yogurt lunch. And then they wonder why they're losing muscle, gaining belly fat, and feel exhausted by mid-afternoon. It's not your discipline, it's actually your protein. So I made you a free guide that fixes the foundation, starting with breakfast. Grab the 30-gram midlife breakfast cheat sheet free at estherblum.com/protein. That's estherblum.com/protein. Go feed yourself, gorgeous. And now back to the show. The point I want to drive home is that plenty of women in their 60s, 70s, and beyond are starting HRT and getting tremendous benefit, especially with vaginal estrogen, which has no timing window at all. Women who are postpartum, having vaginal dryness and pelvic floor issues can start it. Women in their 70s, 80s, 90s can start it. Women who enter the hospital and with a hip fracture and will otherwise leave with a UTI can start it. In fact, ER doctors are now getting hip to this and handing out prescriptions for vaginal estrogen when an elderly lady comes in, because otherwise they know she's going to be back in the ER within a week with a UTI. So here's what the data shows. A 2026 analysis of 30 trials with over 26,000 women found HRT was not associated with increased cancer mortality, and women who started before 60 had a decreased mortality risk. This is life-changing. We're talking about life and death, and the cardiovascular and cognitive benefits are most pronounced when started early, but you're going to get the symptom relief from brain fog and hot flashes. You're going to be able to sleep through the night and have strong bones and have quality of life. That's available at any age. Okay. Now, the bone density benefits may not be as beneficial as when you start earlier, but you will still see beneficial. You can prevent benefits. You can prevent progression. And even that is very meaningful if you are someone who's really battling osteopenia or osteoporosis. So the all or nothing framing is wrong. The decision needs to be individualized to you, the woman, your risk profile, your symptoms, and your goals, and not get refused because you're over the age of 60 or you've been out of menopause for over 10 years, or you've been menopausal for 10 plus years. And really, okay, I've covered a lot of this. Okay, we can keep going to take this to the bank. So this is what I want you to take to the bank. If a doctor tells you it's too late, you do not have a hormone problem, you have a provider problem, and find a new one. All right, this is the most important point. I want you to take notes or look at the show notes when you're done, if you're driving or walking around listening to this, because this is going to help you address how to actually access HRT right now, and the shortages or sourcing issues are very real around estrogen patches and vaginal estrogen and even progesterone. Why aren't there shortages around testosterone? Because testosterone is not FDA approved for women. So that's a whole nother issue. But all the FDA approved hormones right now are on the chopping block a bit. So the good news is, as I mentioned earlier, when the FDA approved, the good news is, when the FDA removed that black box warning label in November of 2025, the demand for HRT it roughly doubled overnight. And estradiol patch prescriptions surged 150% through some telehealth platforms. So now we have difficulty accessing estradiol patches. And if you read reports on this, the industry is saying this situation could last up to 3 years. All the major manufacturers that are producing these hormones are all reporting shortages on at least some doses. And so women are pharmacy hopping. They're switching brands mid-treatment. They're switching delivery systems. And in some cases, and this is like the most upsetting, they're going off HRT entirely while they wait, which is so abrupt and shocking for the body, but also, again, returns your risk of mortality, all-cause mortality, and risk of cardiovascular, bone, cognition, and pelvic floor issues. So it's pretty wild. I mean, out of February 2026, about 5 out of 100 women aged 45 to 54 had been prescribed estrogen-based HRT. That is roughly double the rate from 2023, when fewer than 1 in 20 women in midlife were using hormone therapy. Like across the board, only 4% of women were using HRT. Now that number's up to 5, maybe 6%. So imagine, like, if all women were on HRT, I mean, the scarcity and the shortage would be severe. So we need to address this. This is why I'm doing a lot of advocacy work in DC to advocate for women, myself included. I'm having a hard time also accessing estrogen and vaginal estrogen with this shortage. So what we have right now, I think it's great that the needle's moving in the right direction, that women are getting educated. Every woman I talk to now who wants to come into my practice is really pretty hip to hormones. She's read and understood the difference between synthetic and bioidentical. You know, she's a lot more educated than she was even a year or two ago. But we have this unprecedented demand now that really can't be met fully at present. So we have this huge gap right now between women who could benefit and women who are actually getting treatment. But ultimately, as we close that gap, production needs to catch up with the demand. And so the reality is right now, like, these women, we are all riding at dawn, and women are catching up to 20 plus years of withheld care. And the system was so unprepared for all of us collectively educating, empowering ourselves, uprising and asking what we should have had access to all along. And so the supply chain broke, and the system that has gaslit us for 2 decades just can't handle women finally being heard right now. Let's talk about the workarounds that you can try. You may have to pharmacy shop and go to more boutique, smaller pharmacies rather than large chains. You may have to order online. And understand that when you shop around, pharmacies may not carry all the other options because they often lose money on them. And you may also need your provider to fight with your insurance company for alternatives. So let's talk about first alternatives to the patch. There are estradiol gels. There's estrogel and there's Divigel. And these are topical gels that deliver estradiol through the skin, just like patches. And some women feel slightly more fluctuation with symptoms on the gels because they have kind of a daily peak and trough pattern versus a steadier delivery of a patch. But this usually settles within a few weeks as the body adjusts. And you can get it prescribed 1 or 2 times per day. It's usually once per day. Then there's estradiol cream. This is a compounded cream. The benefit right now of having compounded creams is that you're not going to have a shortage. Compounding pharmacies make products on demand. So BiEst cream is estriol and estradiol, and it's very breast protective. It can be applied 1 to 2 times a day to the inner forearm or thigh, and that delivers systemic estrogen. And so this will give your provider flexibility on dosing, but your provider does need to know how to prescribe and what percentage of estriol versus estradiol. There's 50/50, there's 70/30, there's different formulations that your provider needs to be literate on. There's also an estradiol spray, which is pretty awesome. It's called Ava Mist, and this is a transdermal spray. It's less commonly used, and it's less affected by the shortage. But again, you're going to have your provider fight insurance on this one for coverage because pharmacies lose money on it often. So it's not as widely available. Now I'm going to come to oral estradiol, which is Dr. Makari, who is currently, I don't know if he will remain, but he's currently head of the FDA. And he was talking about options for the patch shortage. And he was saying women can just move to oral estradiol. So the tablets are widely available and they're inexpensive, but they do pass through the liver, and that carries a slightly higher clotting risk than transdermal options. If you've had a history of DVTs, clot, stroke, you should not be on oral estrogen. It's like being on the pill. There's the warning, it's a lower dose, but there is an increased risk. That is a very real risk. But for many women in the interim, it actually is a fine bridge, or it can be a fine long-term option depending on the risk profile. Some women actually use oral estradiol because they need an even higher dose than the patch delivers. It does come in higher doses that women may need for better quality of life. Now you can do, this is kind of cool, and this is what I do. You can switch to a vaginal ring. And this is nice because, when you have the patches, you need to remember to rotate your sides, your delivery sites, and also you look like you've had octopus suction cups on your application sites. The glue around the edge of the patch tends to pick up lint from your fabric. So you're always going to have to be scrubbing off the ring that the patch leaves behind. So if you do a vaginal ring or topical gel or mist, you won't have that struggle. So the Fem ring it delivers systemic estrogen through a vaginal ring, and you wear it 3 months at a time. You can technically wear it during sex. I do not do that because I don't want my husband feeling like he's playing a game of ring toss down there. But it really stays in place. You don't notice it. You don't feel it. And it's great because it also treats the genitourinary symptoms of menopause beautifully. And it's genius for women who don't want to think about applying their HRT, their estrogen every day, and who can't get relief with vaginal estrogen or the estring, which is vaginal estrogen only. It's not systemic, but it's also a ring delivery that is consistent. So what do you do at the pharmacy? How do you navigate when you're switching your prescription? This is really important. You're going to ask your provider to write the prescription as either the estradiol transdermal generic or the therapeutic equivalent. Avoid writing dispense as written language. So the pharmacy has flexibility. They'll say, oh, we're out of the dotty patch, but we can give you the equivalent, which is the Vivel dot. So it gives the pharmacist other options because the prescription is more general. And if your big box pharmacy is out, try small independent pharmacies and try the following online options. And your provider has to put a prescription into these online options. There's Cost Plus Drugs. There is Good RX, which is Mark Cuban's online pharmacy. There is Single Care. There is Costco Pharmacy, and you don't have to be a member of Costco to have access to the pharmacy. There's Walmart and there's Sam's Club. There is also the HRT Club. Now, HRT Club helps in that it's rarely sold out. There's always options available, but it is $100 membership fee for the year. I think it's $12 a month. And you do have to pay cash prices for your HRT. However, it's priced competitively. Like I was on their site and they have estrogen patches available for $60. Well, until my copay is met, my patches used to be $60 before I was using Femring. So they are priced competitively, but I still understand this is not always an equitable option. And that's why I'm working, I'm promoting the more equitable options first, because we want everyone to access no matter what your income level is. So run your prescription through these pharmacy options before filling it, and then compare the price to your insurance copay. And sometimes the cash pay price can beat insurance, especially for generic estradiol. And like my Femring, I know that I got it at CVS. I had to wait almost an hour to go through all the paperwork, but I got it at CVS for $180. But then there was a private pharmacy down the street that was charging $210. But if you pay the retail price, it's $800 or $900. I get the pharmacy to give me a coupon for that. So there's all sorts of workarounds, number one. Number two, if you go and order your things through compounding pharmacies, make sure that it's a really reputable one, because some compounding pharmacies do have dosing variability. And that's a really fair concern if it's a low quality compounder. So find a reputable compounding pharmacy who your menopause trained provider trusts, and that will give you a great option for compounding products. They don't have traditional pharmacy options. You wouldn't get vaginal estrogen or a patch through a compounding pharmacy. So here's your big takeaway, okay? If your doctor cannot get you HRT right now, it's not a problem with HRT. It's a problem with your provider's toolkit. There are at least 7 ways to get estrogen into your body. So find a provider who knows all of them and who will go to bat with your insurance company, and be patient with your provider offices, because this is so hard on the staff. I'm always in touch with providers, and I'm always asking their teams, how are you holding up? And it's a really huge mental strain on them. So give them grace and kindness and be extra patient right now with your providers, because they're doing the best they can and they're working really hard to support you. And it's not their fault that this shortage is happening. All right. The last point I really want to drive home is, and that's often not addressed properly by providers, is that you may still need, and by may still, I mean you will always need vaginal estrogen, even if you're on systemic estrogen. So the misconception is, well, I'm going to provide you a patch or pill or gel, and you don't need vaginal estrogen too. And here's the deal. Systemic estrogen circulates through your whole body, like the patch or a topical cream or gel. But it doesn't always deliver enough to the genitourinary tissues, to the vagina, the vulva, the urethra, and the bladder. And these tissues have their own local needs. And many women on optimal systemic HRT still develop the genitourinary syndrome of menopause and have either vaginal dryness or painful sex, or have to pee all the time in the middle of the night, have recurrent UTIs, or thinning or tearing of the vaginal walls. And so adding that low dose vaginal estrogen on top of systemic HRT is not being redundant. It's actually targeted local treatment for tissue that needs more than what systemic delivery provides, because it rebuilds collagen and elastin and prevents thinning and atrophy. And by the way, when you're done with your vaginal estrogen for your vaginal tissues, you can also put it on your face, because it's going to rebuild collagen in your skin. And so the reality is, though, The genitourinary symptoms of menopause affect up to 80% of women on postmenopausal needs. I watched my mother Botox her bladder, and it was really rough for her. And she really struggled with the genitourinary symptoms of menopause. And the thing is, it's progressive. It doesn't get better on its own, and it often does not get better on systemic HRT alone. And the last thing I want for any of you is to be that old lady in diapers with incontinence issues when this is all preventable. And vaginal estrogen, also remember, it doesn't absorb systemically. Your blood levels of estrogen do not change on vaginal estrogen, which means it's safe for cancer survivors. It's safe during active chemo. And that stupid black box warning label that should have never been on there, that scared everyone off, was applied to vaginal estrogen products by mistake. It should have never been there in the first place. And so what it does is it's going to prevent UTIs as you age. It prevents the urinary sepsis that follows. And it will really help you more comfortable, stay more comfortable. It can help libido because sex isn't painful anymore, really relieves dryness and restores lubrication and hydration, and just keeps that tissue integrity in the vulva and the urethra, which is awesome. And so if you're sexually active, you're going to see a night and day difference. And it's life-saving if you're getting UTIs. So what are the forms that it comes in? Well, it comes in creams like Estrace. These are FDA approved. You get them through your insurance company, through your pharmacy. You can use tablets. You insert the tablets like Vagifem or Imvexi. It comes as a ring like Estring. And it comes as inserts as well. And how you use them is to insert your cream or tablet or insert every night at bedtime. You put a pea-sized amount on your finger, you insert it into the vaginal canal, and then you also apply it vaginally to the inner folds, the urethra, the clitoris. And after 2 weeks, you use it 2 to 3 times a week. And insurance coverage is generally good. But if you find you need it every night, you can use it every night. It's so low dose. It's such a microdose. Like you can have sex after applying it and it won't transfer to your partner. But if you're having sex, apply it after. So it stays put in place. And so if your provider has told you your patch is enough or just never even had a conversation about it, bring in vaginal estrogen. All right, so to close things out, your job as a woman is to educate yourself, to empower yourself with these tools, with this knowledge, with this podcast. Ask the questions and trust your gut. Find providers who have done the work. And if this resonated with you, please share it with the friend who's been told her labs are normal while she feels like a stranger in her own body. Stay tuned for my TED Talk, which is called The Prescription Pad of Misogyny. It's the bigger picture. This episode really lives inside. And if you want to work with me directly, visit my coaching page at estherblum.com. Now go make menopause your bitch. If you loved this episode, follow or subscribe to the Midlife Realignment wherever you listen to podcasts and on YouTube, and leave a review to help other women find this show.